We have a wonderful program for you, and apologize for the slides there. But the topic today is how COVID-19 is causing a seismic shift in patient healthcare behaviors. Specifically, this will be a discussion on how the healthcare ecosystem can embrace the tsunami. We have an incredible panel, nationwide panel today, which we'll get to in a second. But my name is Chris Carabinos. I'm the chair of the Digital Health Society, and I welcome you and appreciate you joining us. We will be recording this, so you can check back on the TAG website in a week, maybe 2 weeks, and we will have this downloadable if you would like to share with other folks. We will not be having chat today since we're using Zoom webinar, but you will be able to submit questions via the Q&A feature, and we'll get to that after the program's conversation on the panel. And so we'll be letting you know when that will be. I would like to share a couple of things here. First off, one of the other activities that the Digital Health Society does is we create an annual or biannual ecosystem report. This is a couple of slides here from the actual physical report. You can download it on the TAG Digital website, specifically here. But this basically captures the 200 plus digital health companies officed in Georgia, Medium headquartered here. We create a huge economic impact in the state of Georgia with a $20 billion economic impact and 44,000 plus employees. And so this report lists all those companies and a lot of the trends and specialties that we enjoy here in Georgia. One of the things I would like to do now is to share and introduce one of our sponsors, Azalea Health, as we could not put on the programs that we do throughout the year without our sponsors. And so I'd like to ask Ellen Knowles with Azalea Health to speak. Ellen?
Hey, Chris, thank you so much. Hello, everyone. Good afternoon or early afternoon, late morning. Thanks for having us and giving us the chance to give a little sponsor message today and share who we are. So a little bit about Azalea. We were founded back in 2008. We're actually headquartered here in Atlanta, Georgia. That's where I am currently. So for more than a decade, we have been focused on helping providers improve patient care and profitability through modern and affordable, easy to use technology. And really over the time, the Azalea ecosystem has grown so much, being the complete 100% cloud-based EHR platform, as well as RCM billing services for both hospitals and ambulatory practices. So our platform is connected via our health system patient index, which enables the seamless and secure workflow for patient information. This is the true one patient, one record experience. And so really, and that's all I wanted to share today. I'm happy to be here and have the opportunity to share a little bit about Azalea. Thanks for having us, Chris, and I'll pass it back to you.
Thank you, Ellen. I really appreciate Azalea's sponsorship as well. I now would like to thank and recognize and thank the committee that has worked for 4 months on this program. It's co-chaired by Michelle Madison and Jody Brainerd. Michelle works with Morse, Manning & Martin, as you can see, and Jody works for the benefit company. But we've had a terrific team who pulled this together, both the theme, the topic, the speakers, the panels. That includes Jim Hall, Dustin Johnson, Richard Powers, Chris Watson, Rebecca Markison, and Paula Resley. So thanks to all of you for the great work that you guys do. And I will, at the end of the program today, I will share the calendar of events for the balance of the year. This is actually our 4th program this year, and we have another 3 programs after this. So we'll be glad to share that with you and extend the invitation for that. At this point, I would like to introduce Michelle Madison.
Hello, everyone.
Go ahead, Michelle. Go ahead.
Thanks, Chris. Hi, everyone. It's my honor today. First, I want to thank our committee members that Chris mentioned. A lot of work went into the presentation for today, and the panel and the moderator are really high quality and with incredible expertise that I'm excited to have shared with everyone today. But it's my honor to introduce our moderator, who is a friend and very accomplished physician, Dr. Jim Morrow. Dr. Morrow graduated from Clemson University and the University of South Carolina School of Medicine. In 2004, he was the winner of the HIMSS Davies Award for Excellence in Electronic Medical Record Implementation. In 2006, he was the Physician Leader of the Year for HIMSS. He has served as the Commissioner of the Certification Commission for Healthcare Information Technology. He serves as the Vice Chairman of the Board of Directors for the Georgia Health Information Exchange, and he's a member of our advisory board for the TAG Digital Health Society. And for those of you that have ever been to a TAG summit before, Dr. Morrow was our moderator when we hosted it down at the Fox and many years thereafter. And so he's been a great member of our advisory board and an incredible leader in the health information technology industry for all of us. So with that, I'm going to turn it over to Dr. Morrow, and thank you so much for moderating today.
And I appreciate those kind words. I hope everybody can hear me okay. I'm getting some acknowledgments from my computer that my microphone's not on, but if you don't hear me, tell me. We do have a fantastic panel today, and I'm very excited about having a chance to talk about this because it's something that everybody in medicine has lived through for the past 15 months or so now, 16 months. So we've got 4 individuals with us. We have Mary Delaney. Mary is the CEO of Vital Incite. That's a population management company. And Mary also spent 2 decades on the provider side of healthcare. And then we have Mike Koriwchak, who is the CEO of ENT of Georgia. And anybody that's been to an ENT doctor in Georgia probably knows ENT of Georgia. He's a longtime advocate, user of healthcare IT, and I think even developer of some. And then we have Rowland, who's the CEO of Endotronics, which is a smart medical device company. I'm very excited to hear what Harry's going to tell us that they're doing because we're getting more involved. Everyone is with those kinds of things. They're helping patients and doctors manage their diseases and avoid poor outcomes. And that's what everybody's looking to do. And then we also have Nick Knowlton, who is with Brightree. That's an EHR for post-acute care and medical equipment markets. He's also the founder of the Commonwealth Health Alliance, which I'm excited to hear about. They're an advocate of interoperability. And if ever there was a nebulous term that is more like smoke than any other I've ever heard, it's got to be interoperability. So I'm excited about that too. So today we want to talk about how healthcare changed with the pandemic and what happened and what we tried to do and have done to improve care, to maintain care, and to continue with what we think is a fantastic medical system in this country. And 2 of the main things that we did were the use of telemedicine, which everybody has been very excited about for a long time. And Michelle was talking about TAG Health and my experiences with them. And, going way back to 2005, the Georgia Partnership for Telehealth, which has a totally different name now, was already involved at that point in trying to do telemedicine, but you couldn't get paid for it. And that's a problem. And so that changed some. So that's a very good thing. We moved at the pandemic beginning to trying to do as much care from the home as we could. I remember back April of last year, I didn't see a single patient in the office. I did everything by telemedicine. And while it's difficult to perform many of the aspects of clinical medicine via telemedicine, it's been very useful in primary care and in other areas. And one of those areas was annual wellness visits. We try to do yearly, obviously, on our Medicare patients. And so that was a very good thing for us. And then the capture of remote data. So that's 2 of the things that I want us to talk about. And there were a ton of problems brought on by the pandemic, but I think those are 2 that we can discuss. And I hope that people that are listening will be able to carry away from here as a good thing, and your time was well spent. So I want to talk to, I'm going to start with Dr. Koriwchak, and I'm butchering your name again, Michael, and you told me it didn't matter, but it always does. Koriwchak is actually how you pronounce it. And I'd like to know, in your practice, what were the main things that changed, or main things that you did to accommodate this pandemic in the last year?
Well, there was a short time where we thought we could stay open, of course, before everything shut down. Once it shut down, we were able to use, 24/7, all of our time to literally retool the entire practice to bring telehealth to us. You know, that was a big challenge because we had to rewrite all of our visit templates. We had to, you know, do a COVID screening once patients started coming back to the office. We had to change the billing internally to accommodate the telehealth modifier and all of that. But I think our practice proved, along with just about every other practice in the country, that healthcare physicians and otherwise are capable of rapidly adapting to changing conditions. And that's an important thing to understand, because through the beginning of meaningful use, you know, we were, you know, cajoled into using electronic medical records. And the rationale was that unless we forced you to do it economically, that we were never going to do it. And our counter at the time was, these products don't work very well. And they were like, well, we don't really care about that. We just want you to use it. And we're going to make you use it because we know you're too dumb to use it on your own. I think this event disproves that when faced with proper conditions, i.e. third-party payers sort of getting out of the way and CMS saying, okay, we're going to pay you the same. You can charge a level 2 or a level 3, both new and established patient, that opened the floodgates for us to be able to do our jobs. And when presented with the correct economic conditions, we turned on a dime. I mean, within a couple of weeks, we chose a platform, we road tested it, we rewrote the templates for the EMR internally. I did that myself because that's what I do. And we were up and running and seeing patients with EMR telehealth templates and billing appropriately within a couple of weeks. So that was the biggest change, of course, as Jim, you had already mentioned. For ENT, the other piece of the puzzle was the safety measures. Because as otolaryngologists, we get our face very close to your face, so we can look in your nose and your mouth and your ears and do office endoscopy and that sort of thing. And so, and PPE was in short supply, including face shields. So we ended up making our own for a while that we used for a few weeks. And that included even taking a piece of flat plexiglass and melting it over a paint can so I could make a visor. And so, you know, because the fear was, you know, we were still on call for the hospital. There's still, you know, we're shut down the office. But, you know, the question is, if you have to go in and see a nosebleed in the ER in a COVID positive patient, you know, how are you going to handle that? And and there were some ENTs on the West Coast that died from this before the threat was fully understood. So the safety gear part was a big piece. I've been going on too long, so I'll cut it off. But we also did some nice technologies with video carts and stuff and built our own gear for a whole lot cheaper than you can buy it off the shelf.
Well, speaking of that, what were some of the specific digital technologies that you found to be particularly helpful?
Well, we switched from doing endoscopy where we put our eye to the eyepiece to doing it all on video. You know, there were a few things that we did on video. There's an exam called a video stroboscopy that has always been video out of necessity. But we looked at doing video for all of our exams, sinus endoscopy, any kind of laryngoscopy. And, you know, can you buy those products? Yes, for the bargain price of between $35,000 and $45,000. But I said, no, we're not going to do that. We're just going to, you know, put it together ourselves. And sure enough, for, you know, $5,000 for an HDMI camera, $750 for a cart, $1,000 for a laptop and some open source software, you're up and running. And so it was the idea of just saying, look, we're going to start with a clean sheet of paper like we all did with COVID, and not accepting the usual limitations that we're used to. So the inexpensive high definition endoscopy camera coupled with open source software and a laptop was the best thing we did.
I just have this visual image of you standing over a piece of plexiglass around a paint can with a blowtorch in your garage trying to.
No, you know what it was? We did it in the warming drawer or in the oven at 250. And yeah, I laid it over a paint can and it got the right shape. But yeah, that's just about what we did.
That's fantastic. That's great ingenuity. I love that. So I mentioned a minute ago that interoperability was sort of a smoke word to me and to, I think, many people in healthcare. If you ever go to a HIMSS meeting, you know, they have huge area devoted to the interoperability hub and that kind of thing. And I remember in trying to become interoperable many, many years ago now, 5 of us met in every meeting room, closet, or office we could find to talk about what would eventually become the Georgia Health Information Network. But still today, I depend on the ENTs in the world faxing me a note so that I know that a medication was changed. And that kind of thing will just drive you up a wall. And Nick Knowlton with Brighttree, you've been working through the Commonwealth Health Alliance on interoperability. I'd love to hear what your opinion is about where that is and how it's helped during this pandemic.
Well, great question. And first and foremost, I appreciate you saying that I was the founder of Commonwealth, but I was one of many people from many organizations who helped put it together. So can't accept too much credit there. But I think that the pandemic accelerated a lot of the interoperability trends that we have seen emerge and take hold over the past several years. If you think about the rules that HHS put out for enforcing the 21st Century Cures Act mandates, they're now requiring EHR vendors to do things like open up FHIR-based APIs to allow for immediate access of updated medication lists per your use case that you just mentioned. Now, interoperability, of course, is not just about technical specifications. You need network effect, you need trust, security, privacy management, auto trail, patient identity, record location services, and the like. And that's where I think some of the larger national bodies, such as Commonwealth Health Alliance and Carry Quality, to name two of them, and even the state HIE, such as Sheehan, can step in and help manage those things that work in concert with advanced and modern technical specifications to make interoperability a reality. And what we mean by this is if you take the mandates for EHR vendors to support certain APIs to move medication information from one care setting to the next, how do they know that you're a physician that has a care relationship with that patient that needs an update? And that's where a lot of the rules are starting to engage with the national networks to bring them to life and to say, we can manage knowing that Nick Knowlton in your practice is the same Nick Knowlton in another care setting. His med list was updated. You need notification, you're subscribed to his care, and your system can automatically pull that in. So I think we see the pandemic as an accelerant to these existing trends. As listening to the stories already on the panel here this morning about people having to move to remote care settings, it made the manual workarounds that care providers typically rely on, such as fax and such as phone calls, made them harder to put in place. If you don't know where the other providers are or what they're going to do, the electronic systems have to talk to one another. I also think that it did accelerate some of the adoption of more advanced interoperability methods, the ones that exist in the cloud, the ones that can be remotely activated. When hospitals said we need to focus our technology resources on public health reporting, or else they're going home because they could be in harm's way or contributing to the problem in a health system. A lot of those technologies that were starting to see some green shoots of adoption all of a sudden started taking off because they could be applied from remote settings, and the people programming the interfaces or activating the interfaces did not necessarily need to be anywhere near where the care settings are to get them to have some impact. I hope that helps start the conversation. I'd love everybody else's opinion, of course, as to what you're seeing out there.
And I would encourage our other panel members to jump in when you have an opinion or a thought. Don't feel like you can't do that, because we want you to do that for sure. And Mary Delaney is with Vital Incite. Mary, you have been you spent 23 years, I think I was told, in the provider space. How have you seen the providers taking charge or taking possession, if you will, of the population management needs of their patients?
Well, related to COVID and the impact, I think what has happened is, so we have provided data to employers, self-funded accounts, so that they can really understand what their needs are, and hopefully try to educate them why they need to help fund primary care, be okay with virtual care, some of the things that, you don't just cost shift, and that doesn't really save you money in the long run. And talking about things like social determinants, very carefully because no one really understood why it would even matter if someone's A1C was not controlled. And COVID was kind of a big wake-up call. There were things that we have been talking about and not really tiptoeing around, but when COVID hit, it's like everyone's ears perked up. I would tell you that we went forward 5 years during the first 6 months. The use of telehealth, I mean, I laughed because before I started Vital Insight, I was with a large primary care group and we studied how to do telehealth and how to get funding and, beat our heads against the wall. And lo and behold, 2 months into it and people are doing telehealth visits. The irony for me is I watch the carriers go, oh, don't worry, employer, we're not going to pay for this very long. We're going to turn this off because they're going to take. So we use data to say, don't. This is the most efficient way. We struggle every day with getting people to connect with their providers. If you make it easier, so once they have a real relationship, they can, they don't leave work, they don't leave their child somewhere else, and they can actually connect. We've had a really nice impact. We've been able to show an impact already on people following up with care appropriately. So I can't even remember, I went through so much in that, but to me, it really brought to life, things that we've wanted employers to understand because they are the ultimate payers. They have the influence over the carriers. So, and the other thing I just want to share too is that we've preached primary care payments as being so critical. Lo and behold, there was nothing better than those videos of these primary care providers going out there, giving their lives every day for them to go, oh, so if we would have had a relationship with a primary care provider, this would have been a lot easier. So I think they're holding on to all of these lessons learned, which is a blessing.
It is a blessing. And you've got actionable data showing differences in outcomes that you can present to these employers. Are they, for the most part, willing to do what it takes to have these things happen? Because that's another roadblock sometimes.
Well, you have to remember, we don't work with all employers. We work with employers that were motivated to use data. So we're really lucky. We picked the people who want to do something with it, and they are really motivated. They were motivated to start with, although not as motivated as always we wanted, but now they are really motivated. I would tell you, we've worked harder in the last, 18 months now, probably 15 months than we ever have, but it was because finally they were going, oh, you told me about that. Can you show me more information? Can you tell me how to do this now? Can we revisit it? So I do think that for a subset of the population of the employers, they are awake and ready to go.
That's excellent. I'm glad.
Mary, we had a very similar experience pre-COVID. I went to HIMSS in 2016 with the express mission of finding a telehealth product for our practice. I couldn't find one. The closest thing I could find was a very nice gentleman who was the CEO of his telehealth company and showed me these amazing pictures of facilities all over the globe where they were monitoring what was going on. And I mean, I had drool coming down the corner of my mouth here and my credit card in my hand going, I'll buy it. How much? And he says, I can't sell it to you. I said, what are you talking about? He says, there are no telehealth products for doctors. All of the telehealth products were purchased by insurance companies and very large corporations. And, that was your, dial a doc or dial a nurse that came through your insurance company, through Blue Cross Blue Shield or Cigna, and who you talked to had no relationship to your regular doctor. One very good thing that happened as a result of COVID is that telehealth was redefined, in my opinion, the way it should have been defined all along, which is an extension, not the only definition, but the primary one is to make telehealth the extension of the brick and mortar practices of physicians and others. And now we're kind of back on track with that and sort of back in the middle of the fairway with it. So that was very good.
Yep. Yeah, we actually have some stats to quantify that now too. In February of 2020, about 1% of Medicare primary care visits were done through telehealth. And by April, that was nearly 50%. And the technology division of United Healthcare, Optum, reports that demand still remains more than 10 times what it was pre-pandemic. So I think you talk to most industry stakeholders, the genie's not going back in the bottle. Telehealth is here to stay. And while we might see, some demand rightfully return to face-to-face encounters, it is recognized by payers and employers, at least that I'm exposed to, that this is something that's of value, can help take costs out of the system and do the right thing for patients and providers alike.
Yeah, one of the big things that we saw last year was every employer screams over the ER utilization numbers and the cost of ER, especially for non-emergent care. We use Johns Hopkins risk indexing that lets us really define non-emergent care. We saw non-emergent ER care go down 25%. It's the first time, and we joked with our employers that they've been working on this for 8 years. It took a pandemic to get people out of the stinking ER and instead connecting to their primary care, but we could tell they were using their virtual services. And again, even we had a peak in those insurance telehealth visits and those national corporate things, but those are not sustainable. Those peak up and they go down. What we see sustainable is the real relationship with their providers. And that's exciting. And into Q1, we still saw that non-emergent ER was still down 25%. So we're hoping that that's going to stay too.
Well, it's going to be one of the major challenges going forward is to define what the role of telehealth is going to be, by doctors, by specialty, by facility, by geographic region, across the country as COVID hopefully gets farther and farther in the rearview mirror. And we say, okay, what should the role be? And then work on making the products more adaptable to what those roles are going to be. Because one of our pain points going forward now is that in terms of workflow, telehealth is not what it's cracked up to be. And if your volume gets above a certain point, it actually hurts financially because it takes 30 minutes for a telehealth visit because you spend the first 15 half the time getting the patient's technology working because they don't know how to reverse their camera or unmute their microphone and all those things, right? We struggle with those in a setting like this, and we're all experienced at it. You get somebody who's not really used their smartphone very much or something, and it takes 30 minutes to get a 5-minute visit in. So still things to work on.
Well, we're reaching into their homes with the camera, but also we've come up with new ways, and companies like Endotronics, who Harry Rowland is with, have come up with new ways to connect to patients. So Harry, I want to drag you in here. I'm not leaving you out, I promise. In our practice, we're trying to see all of our heart failure patients on a Q90 basis every 90 days. And it's been shown to provide better outcomes, but I know your company's doing a lot of things that can help with outcomes. And I'd love to hear how that's been affected by the pandemic, whether it's up or down or better or worse. What is going on with there?
All of the above. And I didn't have anything to say. The panelists are really covering those topics nicely. But several of those themes they talked about impact us, and it's a little different for us. So the negative impact from COVID was just a disruption in clinical trials, and we're a new emerging company. We're running clinical trials for approval, and you have to just shut down all those resources to manage what's going on the front line of medicine. So negative disruption and slowdown in 2020 from that sense. But from everything everybody else talked about, there's a massive shift in expectations and behaviors that happened, which we see as a multi-year tailwind coming out of it. And the barriers before getting telemedicine and being able to do check-ins to patients remotely, many were structural. Reimbursement, everybody's got to keep the lights on, and if you can't get paid, everybody's got to get paid and keep the lights on. So getting those barriers removed, a lot of the stuff that Dr. Koriwchak talked about, the innovation in the practice office, using technologies we know that work as consumers into the physician's office has been very hard if that's viewed as a medical device. But FDA innovating around digital health and viewing these software systems and EHRs separately from devices. So you remove a structural impediment to innovation by being able to get those technologies out there. You remove the reimbursement impediment by actually paying services. And now all of a sudden, these technologies can flow and people can figure out how to work with them. And as Dr. Koriwchak mentioned, we're not there yet. There's still workflow things that we need to work through to make these technologies work. But we're at the start of that, and people are going to figure that out. And we at Endotronics agree with the premise that telehealth is not going to be a third-party system. We just view fundamentally healthcare as it's a relationship between a patient and a clinician, and it has been for thousands of years, and it will continue to be. And we want to make that visit better and smarter. And COVID made people rethink, just kind of get off autopilot. That's the way we did things, but what's the best way to do things? And getting to your question around that that 90-day follow-up with a heart failure patient, why is it 90 days? What's the best way to follow up with that heart failure patient? And for many of our patients, medication changes maybe once a month, at least in a period of care optimization. You certainly can't do that in COVID. These patients don't want to take the exposure. But we have tools and technologies to position clinicians to do everything they'd want to do in an office visit with remote. So that's what our system's about. So an office visit for a heart failure patient, see the patient, doc's doing some visual assessments, seeing what's going on, asking the patient how they're feeling, taking vital sign measurements. And for a heart failure patient, you're doing a qualitative assessment of congestion. So are the veins, their edema? We take all that information, we allow that to happen quantitatively, reliably from the patient's home, and we get that multiple time periods a week. So clinicians, when they need to make those medication change decisions, which are in the best interest of the patients, they can do it with confidence. They can do it whenever they need to. And now with all the payment change, they can get paid to do that. So they can think about adjusting their practice patterns that are in the best interest of the patients to get better outcomes. They have the technology to do that, and then figure out how to optimize. Where does my remote management fit in with my practice? Where does the office visit fit in with my practice? I have to go check on my patients hospitalized. It's just another pillar of the care delivery model. And COVID has forced people to come off autopilot and say, you know what, there's a better way to do that. And I'm ready to take that on.
Harry, your device is what? It's a wireless thing that goes in the pulmonary artery. Did I read that right?
Yes. So we have two products. We have our flagship product is the medical device that you just talked about. It's a pulmonary artery pressure sensor. It's implanted via right heart catheterization. It's about a 1-hour procedure. Patient goes home same day. So we leave a sensor permanently in their pulmonary artery. And then the patient at home holds up a handheld device against their chest 20 seconds a day to measure their pressures inside their heart. So we replace that catheter-based measurement, and we can give that every day. It's very easy. So that's the core product. But we offer a second product. We wrapped around that an easy way to layer on blood pressure, weight, heart rate, and patient symptoms and patient connectivity with their clinician, because we realized not everybody had that. So we bring those two products together so we get all that information from the patient's home reliably to the cardiology program to manage that patient.
That's really awesome. I don't know if everybody else gets the technical parts of that, but I mean, that could be on par with like home blood glucose monitoring for, I could see you guys coming up, and maybe you've done it already, which is to come up with mathematical models that predict when a patient's going to decompensate, but it gives you 12 hours of lead time. So you can do a little fix half a day early as opposed to an ER visit and an ICU stay.
There's a lot of innovation to happen there. Really, with the pulmonary pressure, you have days to weeks in advance of that decompensation event. So there's time. It's not an emergency event that if you don't respond in an hour, you're in trouble. No, those pressures in the heart will trend up over days to weeks. Clinician has time to see that the next day or next couple of days. It's part of their workflow. They see it's moving. They know exactly how to treat it. It's a medication change for the most part, whether it's a diuretic or get the patient on Entresto or SGLT2. They know exactly what to do. They've got time to do it. They call the patient. Now they can call and see the patient with telehealth and get paid to do that, rather than try to schedule the patient to come in for an office visit 30 days later. They miss the window. Patient compensates. They're in the hospital.
Yeah.
Deteriorates from there. So,
yeah.
But we want to automate that. We want to make it as fast as possible, as scalable as possible. So it's really in the early innings, just like maybe where all the continuous glucometers and the Libres and all that stuff was in diabetes 10 years ago. We're at the early innings of that for heart failure. So it's exciting.
Funny when you talk about that, because even the CGMs, the Libres are, and even blood pressure cuffs are something that COVID, we've talked to clients about paying for it. It makes it easier. You can get people in, they're paying already. Some of these diabetes drugs are $3,600 a month. Why not pay for a CGM and know if it's working? And you could not get them to move the needle. Well, suddenly they can't go in for a test, not like they did before anyways, but they have a reason now. And they are then willing to pay for some of this stuff. And we realize the outcomes are much better.
And if you look at the value-based contracts that are spreading around more and more every day, it seems like this is going to be so much more important as time passes. I mean, one of the first things we realized was, and to Harry's point a minute ago, YQ90, one of the first things we realized was what's happening to our patients between those visits, whether it's 90 days or 180, is ridiculous. And we're trying to catch up with them in a 20, 25-minute visit, if we're lucky, for what's going on. And we're also behind the 8 ball. So the idea of being able to know what's happening with heart failure patients and other patients, as it happens, because that's really, if we're going to take care of people in general and do a better job of it, and certainly if we're going to do it in a value-based world, that's what we have to know. We have to know what's happening now, not just because they had an appointment 2.5 months from now. So I love that idea. I think that you're right. I think this is the very birth of that. And we've all seen what's happened with Dexcom and Libre and so forth. And I hope it does follow that. I think it would be fantastic.
I think one thing we're fascinated with the value-based care contracting and all the innovation that Mary is into as well is one challenge that we have is our patient population 70% Medicare. And so with all the innovation that's happened in telehealth and continuous glucose monitors, that was driven by the self-insured employer. They see the impact. They know what it means to their patients and their employees, their employees' families. So they're acting on it. How do we get that level of innovation in moving the needle when you're working with Medicare, who they absolutely care about it, but the accountability and knowing how those dollars impact you and being able to move fast on innovative models, it's not an easy challenge to solve. So if you guys have any ideas on how to do that value-based care contracting and these different risk-based models and case rate payments in the Medicare space, we're all ears for that.
Well, the first thing we're going to have to do is forget about the concept of value-based care as it's defined by contracting and by high tech and by MACRA and all that kind of stuff. Notice that all this really neat stuff that happened, right? There's no MACRA criteria that drove your imagination, Harry, right? I mean, Mary, this wasn't a MACRA driven thing. This was going face to face with your employers in a once in 100-year situation and showing the value face to face. So I think another thing that we're learning as we speak here in real time is that, this didn't happen because the government put up a hoop for y'all to jump through. Y'all just knew what needed to happen and you did it. And that's where it's going to happen. That's where the rubber's going to meet the road. It's not going to be, because, I checked all my boxes and I'm a good boy. That doesn't do squat. This is the stuff that actually where the rubber meets the road and good things happen.
Well, I'll tell you, it's funny. We have one of our board members gave me a quote that I hold on to, and I don't know it by heart right now, but it's basically quit getting frustrated trying to change what exists, invent something totally wonderful, and help the other thing become extinct. Because when I talk to employers or carriers and they're talking about quality outcomes, I'm like, these doctors aren't doing it because you don't pay squat. Like they can't get people in the door because you don't allow the people to show up. Or you're looking at a certain population as social determinants that doesn't even have access to transportation. We've missed it. So I think the trick really is if we can get the ears and eyes of self-funded employers, and obviously there's a lot more Medicare dollars going out there, but we can move the needle because they're hungry for a different type of healthcare system. Yep.
They don't have to prevent too many hospitalizations of a heart failure patient or a diabetic patient with an amputation to fund everything that they've tried to do for the last 6 months.
Yep.
Yeah.
Yep.
Well, yeah, I bet if Harry's pressure transducer saves one ICU stay and week in the hospital, you paid for the procedure and for the device, and then the rest is gravy after that.
Absolutely.
Oh, yeah. Harry and I will be talking again.
So Harry, most of the people that are associated with TAG know the name Pat Williams. She was an icon in TAG Health and ran the board for years and years and years. And she has worked tirelessly fighting against the broadband challenges in Georgia. Now, when people talk about Georgia and think about Georgia, a lot of times they think about Atlanta and you think about 5G and all this stuff. But in South Georgia and rural parts of Georgia, you struggle to get broadband coverage. So how are companies like yours working with that problem to try to make that assistance accessible by the people who live in those areas?
So that's a great question. We're not tackling that one fully ourselves, but we're absolutely impacted by it. But I can share an anecdote. When we when we started on two anecdotes from our story. One is we were originally a next generation sensor company, and it was an epiphany when we realized clinicians are not ready to drive this Ferrari. They're not even getting weight or blood pressure. They don't even have time in their practice to look at this data. We don't handle that problem first, we're in trouble. So we focused on how do we integrate into the clinician's office, work for them, and make it work for them, period. And they can see this data so they're ready to accept this PA pressure data, which can change the course of their heart failure patients. So we focused on that. And by focusing on that, so, well, we need to go test this in the real world with patients. How's a cardiologist going to integrate it into his or her practice? So our first experience in there was in a 3-hour catchment area of San Antonio, Texas, which I think is probably very similar to many parts of South Georgia. I lived in Warner Robins, Georgia for several years. So I know you can drive a little bit out of that, and there's not many people around everywhere. And we found out very early on, for some of our first 10, 15 patients, I mean, we're driving to mobile homes in national forests. And we're learning for our patient population, they're in 75, 80, they don't have smartphones. They're not walking around with Apple Watches and Fitbits and looking to measure their steps every day. So it's okay, we need to meet these patients where they are. We need to bring this technology to them in a way that they're not going to be afraid of it. They're not worried they're going to break it. It's going to work for them. And that has to reliably work. If we have this great technology, we can't send data to or from that patient, we're adding zero value. So we take connectivity very seriously, so we pay for it. So we have cellular chips embedded in tablets. So we take care of everything to make sure that 75, 80-year-old patient has everything they need to be successful and communicating with their clinician without coming into the office. And because of that, actually, reliability concerns, we didn't implement any video early on just because we couldn't think it was going to be reliable. So let's just make sure we can get packets of data reliably from one spot to another. And then docs and nurses can call the patient or see them in an office visit. But the more and more that broadband comes out, 5G comes out, the more and more value you can deliver from the patient's home without them having to come into the office. So the high-res imaging, you're kind of doing an echo view with them, stuff like that all becomes possible. So it impacts us, and for us there, we're just kind of waiting for technologies to catch up, payments to catch up. And I think a lot of innovation is going to come from 5G rollout for sure.
Okay. So Mary, getting back to population health, because it's something that a few years ago I didn't know anything about, and now I know very little about, but I know something about it because I'm certainly involved with it some now. With data aggregation, the analytics that you have, you're able to point people towards the right plan, the right kind of thing to do. How does that work with what you're trying to do in your everyday life?
So we integrate data through their health plans, PBM, any wellness services, anything outsourced, and we do it on a belly button level. And then we use Johns Hopkins risk indexing. So we have information on every belly button on the plan. We can look at how they're utilizing care, what care do they need? Is there a positive impact from the things they've invested in? Are there other strategies that can be put in place? So what I think it has done is given the employer hard data to make more difficult decisions, where before every HR person was afraid to do anything different because they could get fired if it failed. So everybody went to high deductible plans. Everybody cost shifted here. Everybody, you're just following what probably the carrier is telling you and your benefit advisor is telling you to do. Well, now they have their own data and they can see firsthand the cost of, don't take care of someone's diabetes and then they go into dialysis. So why is it worth trying to prevent type 2 diabetes in the beginning? Why can we now see that prevention matters?
But you're dealing with employers who, as you said a minute ago, are already highly motivated. They're coming to you and they're interested. How are we going to spread this to all these other people, employers and insurance plans, who are less interested, less motivated? Other words I really don't want to use about them, but I do believe about them. So how can we can we and how can we get them more involved and get them to be part of this?
Well, our goal is to be able to prove healthcare can be different and publish things that show that. So right now, we have 140 employers from Anchorage, Alaska to Miami, east to west coast. And probably 30% of those still don't really do much with the data. Our trend is still, we had a 0% trend for 2 years in a row. Now COVID helped that, but we were only at 2% before that, where the market is what they say 7.5 to 10% trend. So if we can show that, we've helped employers move PBMs and seen a 20% reduction in drug spend. Drug spend is 30% of their total healthcare dollar. If you get rid of 20% of that, you can invest that in healthy foods, in transportation, in digital health, in telemonitoring, other things that can really change it. So the only thing we can do is, one, continue to fight the carriers that they have to share the data, because that is a huge battle across the board, and we have to have accurate and complete data. And to have the wherewithal to continue to tell the story very objectively so that people who are not in healthcare can understand it, because our world is really complicated, as we all know.
Nothing more complicated than hospital billing. That's what I've learned.
And they make it more complicated, I think, deliberately by carrier. Everybody has a slightly different way to show it.
And as I mentioned earlier, gathering all that data is great, but getting it into the individual EHR, the 89 different ones that are still out there, and that's probably half the number. But Nick, you've done, as you mentioned earlier, a lot of work in trying to get this information spread around, but how can we, and how can the people that are listening today and watching us, how can we go about making that happen on a much better scale than it is now? Is there anything at all that we can do?
Yeah, I think first and foremost, it comes with understanding the art of the possible, right? There are systems and mechanisms for doing this today that are out there. And we always recommend that individuals that want to get engaged, especially in the provider community, recognize what is possible. Know that interoperability is happening now and you can do it and you need to demand it. And that includes talking with, other care providers, be it, whoever's faxing you those med updates on patients, and talking through the different options for being able to move forward. What we very often find is that even establishing a simple use case gets providers very jazzed up about, wow, I just, did something I didn't even know my EHR could support. Let's talk about fleshing this out. Let's talk about, coming together as a community and establishing, more and different types of interoperability. So when we work with post-acute care providers, very often they don't even know what the capabilities of their own EHR systems are. So along with a conversation with the other care providers that are part of, your team taking care of these chronically ill patients, talking with your vendor and asking them how they, support basic modalities of interoperability is a great place to start. Both wearing my Commonwealth hat and wearing my vendor hat, we do get engaged very heavily with provider organizations that say they need help, starting a conversation. And bringing in some of those points about, data, one of the things that we actually commissioned Chris's group to do a couple years ago was to study what are the attitudes of care providers around interoperability, especially as relates to care that's delivered in the home, and what are the attitudes of those care providers who are servicing patients in the home. Your home health nurses, your hospice providers, even, some of the HME folks that we deal with. And I think bringing that type of data to bear to show people that referral sources care who their care delivery partners are, they're willing to switch who cares for that patient in the home if they can end, the lack of visibility into care progression in the home. So the type of things that, Harry's organization are doing to bring to light not just data, but actionable KPIs to get in front of a patient's, care pathway, that excites referring providers. And if they're talking to their EHR vendors, it better excite their EHR vendors too, right? As value-based care hits the providers first and foremost, if you as a physician have to take on financial responsibility for a patient, you know that it's possible to use technology to better care for those patients and, perform better financially within your own operation. It gives you an opportunity to have a much more, constructive conversation with the technology vendors that you touch, to share with them your expectations. And then in the vendor community, it's up to us to, plumb things up. So we always like to say that, once you establish networks, it's much easier to add additional functionality to them. So Commonwealth, for instance, was formed to solve for the patient identity issue. We're one of the few developed countries that doesn't have a national patient identifier. But to make that actionable, you also have to solve for a record location, i.e. where is Nick Knowlton been, now that we've established we can identify him, between different systems, and then provide real value to clinicians to start using it. Well, we've crested over 1 billion clinical documents exchanged earlier this year. And some of those very underpinnings that help drive the patient identity network, they're also driving, where has this patient shown up? So took an ambulance ride and you're my PCP, you should be able to get a notification on that. If you're a home care provider, you should be able to get a notification so you can potentially intervene and get that patient back and stable at home. So as these networks get put in place and have established some basic use cases for, hey, I can query for my patient's information, it becomes about how do we take all those tools and drive them to have impact at a population level. So how do we take record location advice to empower you as a clinician to know there is a way for me to find out where my patient has been. So I think this may have been a long-winded way of getting back to it, but an educated care provider is very well equipped to go have these conversations with their technology partners and say, hey, I heard that this sort of thing is now a capability. I want to know how I can participate. Please tell me, or let me know if I need to bring in another vendor or switch vendors.
So can I throw a question at you? How,
Sure.
In terms of health information exchanges, what typically, historically, when those first came up, they would die as soon as the startup money dried up because nobody wanted to pay for them. So what's the business model that keeps the stuff that you're doing cash flowing, and who's paying for it, and how are you showing the value, and how is it surviving after the startup money?
So great question. To put a finer point on that failure mode that you mentioned, a lot of state HIEs were basically given large checks to jump off a cliff and see if they could fund building wings on their way down. Some of them were wildly successful, and some of them very predictably crashed into the rocks below. One of the things that we in the vendor community noticed, and this was going back, 2012-ish, was that some of those HIEs were asking clinicians to get out of your EHR and go into some proprietary portal if you want to view outside health information. As predicted, the adoption was abysmal. So when we put Commonwealth together, and Care Quality certainly has similar philosophies in it, put the information in the right place at the right time. Do not distract clinicians. Do not tell them to go do something different. Invest in your products and workflow, enable it. And if you would have sat with those of us who were involved in the very early days of Commonwealth, maybe 1 or 2 years into the journey, we actually shared all of our own personal stories. From one of the other co-founders, he lost a cousin because his dad didn't follow him to the ER, and they couldn't, advise in time what was wrong with the poor guy. So everybody was driven by a mission to do it. And we knew that within the EHR world, we could put these networks in place, and it would be good business for doing the right things for providers and patients alike. It may have also been driven a little bit by the fact that, hey, the head of the ONC was telling us at the time, if you guys don't figure out how to handle patient identity and move past that, then Congress is going to tell me to do it, and you guys won't like it, the providers won't like it, nobody will like what we do, so go figure it out on your own. And that was actually the genesis point for two of the individuals to start talking about the idea that became Commonwealth. This is, we've reached the tipping point, the hockey stick, so is Care Quality. The two networks are speaking to one another, but you talk to any of us who are involved in those national level interop conversations, we're just scratching the surface of the power of what can be done with this. What if Harry's medical devices were a connected endpoint on that? You as care providers would not have to say, I need to subscribe to this HIE, or I need to go get a point-to-point interface put in place with Harry's group. If that information can just flow and you gain the power of national networks with, hundreds of millions of covered lives and tens of thousands of provider sites connected, that's where we see this, conversation going next, is how do you take what was built to be a basic thin level, national level network for I need my care information to follow me, to really be empowering clinicians at the point of care to make the right decisions based on the data they have at their fingertips.
Please solve that problem in the next 12 months. That would be great. Thank you.
Well, a lot of
Excellent.
things have been, and it's amazing to me in the 20 years of using healthcare IT, in the last 16 months, last year, it has changed so dramatically, and people's interest in it is different. People's desire to use it and to be part of it is different. And I think it will end up at one point in the long run, it will be one of the good things that came out of a pandemic. And there are not going to be too many of those.
Mm-hmm.
But I think that will be one of them.
Yep.
We are up against the clock, and we probably have some questions. And so I'm going to turn it over to Chris Watson and ask Chris what our questions are from our participants.
Great. Thank you so much. And thanks for all the great comments. We do have a couple of questions coming in for the Q&A, but I would remind you as an attendee, if you have questions, please feel free to enter them into the Q&A button at the top of your screen, at the bottom of your screen. So we did have a question about kind of the timing and the time it takes for some of the virtual visits that are taking place. Dr. Kay, you mentioned they're taking a little bit longer because of the technology support that's required to make sure the patient is online and able to perform the visit. Are there any other comments, Dr. Morrow, maybe even from you?
Well, I don't think there's any question that it takes longer. And Michael's point about people having difficulty with the technology is very true. But also in a visit like that, invariably there's some time also spent about, isn't it remarkable that we're able to do this? And it's a big help that we're able to do this. And those things are all true, but you wouldn't be doing that if you were sitting in the office. And so it absolutely does take longer. My nurses who do triage for a few minutes before I even get on the video call are spending more time doing that part of their work as well. And I think invariably you do lose something in that, but the opposite of that is the blessing of being able to see patients when they're in their home. Because forever we couldn't do it. Well, we couldn't get paid for it, which is the same thing. And so now in the fact that we can do it, I think that really erases all the problems with time, and just the fact that we can communicate with them better, I think is going to change everything in the long run.
Definitely. There are some cultural norms that need to be worked out too. And Jim, I bet you've come across this as well, which is that if you have a telehealth appointment at 2:10, and it's mixed in with your inpatient, your physical visits, your in-person visits, at 2:11, the phone rings and the patient's like, hey, where are you? And it's like, well, I'm running a little bit behind. So, I wonder if at some point, instead of having your appointment at 2:10, you do it like the cable company does and says, well, we'll be at your house, in a window. It's not going to be that big a window.
No. Let's not go there.
maybe not.
Maybe
like
give them a counter to say he will be with you in 5 minutes or something.
Something like that, or some sort of feedback that sort of gives them a little bit more of a clue as to when you're going to be able to make contact with them. Because with the waiting room exam room model, right? We hold everybody captive and say you're going to sit there until we're ready. And without that, then how do you solve the problem? In a way that you can stay at work and just keep doing what you're doing and, see a 15, 10, 5, we'll see you right now kind of thing. But that's one of the problems we need to solve.
I think that's why we've done blocks of telemedicine. So we're not trying to mix it in with in-person visits, because you're right, that's very difficult. And it invariably becomes a failure
Do you do them every day, Jim? Do you have?
We don't, just because we don't have the need for them right now. But we have blocks during the week when we do telemedicine. Yeah, we're still doing some. And it's great for, like I mentioned, for people that have difficulty getting here, for people that have to be affirmed with home health visits and such. They have to have a face-to-face, and now we can do that on telemedicine. So that's a big help. That's a big help. What else you got, Chris?
Kind of along those same lines, we get a question from Steve Keck asking about, telemedicine being implemented in local practices. How has HIPAA compliance been maintained through some of those, or do you have any reservations or observations about some of the changing dynamics around HIPAA as it relates to telehealth visits?
Well, I think a part of what CMS did was to relax those guidelines a little bit. And so, yeah, had they not done that, we would have been forced to move slowly because, they always dangle those, $25,000 per occurrence fines out in front of you,
right,
and force you to move slowly. But I think they even said, FaceTime was legal. And so, yeah, and there had been times where our product has kind of collapsed in front of us, and we've said, okay, do you have an iPhone? Okay, great. Let's just do this in the simple way. And, we've had a lot of visits that just end up being FaceTime phone calls.
Okay. Yeah. Well, we have another question, Nick. I think this was really more toward your world, representing the post-acute care space. So you may want to take just a minute and describe really what that is. We talked a lot about digital remote monitoring, capture of data, and also the conducting those telehealth visits. How have you seen that play out in the post-acute care space? And is it different than the view that we're hearing from the physicians here today?
Sure. So great question. So first and foremost, when we say post-acute, we typically mean the care domains that are represented post-discharge for patients that need follow-up care. So that'd be, skilled nursing facilities to assisted living facilities to home health, hospice, private duty home care, and even our home medical equipment providers are playing a much bigger role in that space. We also are shifting the terminology a little bit to call it out-of-hospital care. If you line it up with population health management, it's about keeping patients healthy at home so they don't have that acute encounter to get a diabetic foot amputation, for instance, in the first place. So we're seeing a massive uptick in remote patient monitoring technologies. I think one of the other, here to stay trends that we saw coming out of the pandemic was the shift to, higher acuity care at home, really. So you're seeing a lot of skilled nursing at home and even some hospital at home type experiments being run around the country. And there was an absolute necessity during the pandemic for patients who would be at risk staying in a facility with an outbreak to somehow be managed at home. And necessity being the mother of invention, we absolutely saw an uptick in the use of remote patient monitoring and telehealth type technologies during the pandemic. So just to give a couple, examples of that, in the HME world, our providers were doing, setups for patients on CPAPs over, telehealth systems that they had cobbled together. We worked feverishly to, include some of the additional functionality in our systems to account for reporting mechanisms and making sure things would be fine with the payers so they could, stay in business and take care of those patients. Certainly for remote patient monitoring at home, there are a lot more modern and I think inclusive systems out there that are now capable of reporting information back. There's a number of initiatives around the country that are spooled up on how do you take data collected in the home. Mary alluded to social determinants of health earlier. There's a whole initiative just around how do you, normalize SDOH data so that it can be consumed in EHR or transmitted to a discharge coordinator to say, we just arrived at this patient's home to drop off an oxygen concentrator. They have no access to food, transportation, they're in a wheelchair and they don't have a ramp. If you don't do something, this patient's gonna be back in your lap within 48 hours, sort of thing. So tying together existing technologies off the shelf was the name of the game in the pandemic. But I think we're gonna see a lot of growth in the next 12 months over the sophistication and thoughtfulness of the systems around workflows to make them easier for both the post-acute care providers and the trading partners, be it at the health systems or in the ambulatory physician practices work smoothly.
Just one comment on that. I think COVID is forcing everybody to just rethink workflows. How do I want to work? What's the way to work? Can I do this better? So that the concept of workflows is just permeating every conversation we have.
That's excellent. Well, I think we have time. I'd love to go around the horn and each of you spend about a minute. We're looking at the next 12 months and how these changes that were forced upon the industry during and embraced across the healthcare industry due to the pandemic. How do you look at the next 10 years? If you could just think for a second about what the next 10 years looks like when we're having this same conversation. And we're looking back, where do you see those big advances that we're going to build on top of those changes that have occurred due to COVID? So we'll start, Mary, if we could start with you. Do you have specific thoughts you'd love to share? Let's each try to spend about a minute.
The problem is with 1 minute. I would love to see us really finally shift to prevention much more than we had in the past and pay for that, have the right systems in place to be able to do that. If you think about 35% of the commercial payer spend is completely wasted in the US. If you put 35% of what we spend on healthcare in the commercial world back in the system, we could pay for food, transportation, ramps. There's so much education. There's so much we could do to change what it is and reduce the demand, but then provide the right care to the right person.
Great point. Harry, how about you?
I think over the next 10 years, physicians' voices, clinicians' voices are going to be heard a lot more. If you look back over the last 10, there were structural changes which drove differences. And I think some of the structural changes that happened with COVID, change of payment models, reducing barriers, opening up access to new technologies, that puts the clinician's voice back into the right level of context. And I think that'll change. These workflows will become more established that really do work for the patient and clinician, and it comes from that need rather than top down. So I think those structural barriers that have changed in patients' expectations and that consumer expectations, that getting a taste of that's really going to flourish over the next 10 years, I think.
I'm sure that will be welcomed by Dr. Morrow and Dr. K here. Let's round off with the vendors and then we'll go to the doctors to get their opinion over the next 10 years. So Nick, you want to share your thoughts? I think you might be on mute, Nick. We're not able to.
Oh, sorry.
There you go.
That better?
Yes.
Yeah, speaking of technology challenge, right? First and foremost, I agree with everything that Mary and Harry just said. I will throw in patient as a consumer and seriousness around bringing the patient experience up to the level they've come to expect. Everybody spent a lot of the pandemic ordering Amazon groceries and knew exactly where everything they ordered was. You transition that to compare how did things work for patients who are expected to be consumers in the healthcare world. I think that we're absolutely going to solve for a lot of those workflows so that patients feel they're getting the experience there that they get, in their day-to-day lives.
Great point. So Dr. K, I see that you're on mute, but we'll go ahead and bring you off and then mute over you the next 10 years. What do you see from your patient population being more informed, more consumer oriented, wanting that visibility and actually moving into that preventative mode that Mary spoke about? What are your thoughts for the next 10 years?
It's going to depend critically on how the federal government behaves. Right. There are two narratives out there. One is a top-down approach. One is a bottom-up approach. What you're seeing in this conversation this morning/afternoon is all bottom-up stuff, right? This is where innovators see a need. They create a vision. They enable and fulfill that vision, and they are successful. That is a bottom-up paradigm. And if the nation goes top-down, all of this stuff is going to have a hard time surviving. So the short answer is it depends.
Very, very good. Yes, great observation. And we'll wrap it up with you, Dr. Morrow.
Well, I think one of the main things we're going to see is what we've seen just the tip of right now, which is the ability to look into the patient's home and see how they're doing when they're not here. And I mentioned that earlier, you know, being able to prevent readmissions, being able to prevent bad outcomes, to anticipate things with things like Harry's company's doing. I think this is going to expand dramatically now because we have seen what can be done. Employers didn't want people to work from home for decades because they didn't think they would work. And now what I see is people who are working from home are not stopping. They don't know when to turn it off, and they're doing much more work than they were in the office. And I think now that people have seen that we can have better outcomes, we can actually save money and lives, I think the next 10 years are going to be incredible. I wish I was going to be around to practice for all of those, but I pray that I won't be. But I want to watch it, and I want to be part of it. I want it to help my health when I'm at that point. And so I think it's going to be very exciting, but I think the next 10 years are going to be very different from the last 10. And Michael mentioned the government, and heaven only knows what can happen. But I think because people have seen that we can benefit from this, the drive is going to be sure that we do benefit from this.
Right. And that's really kind of the focus of this panel today, was really what's not going to change, how are we adapting, and how are we embracing all that change. So we'll end on that very positive note, and we'll turn it back over to Chris Carabinos, our TAG Health president, and the sponsors.
Thank you very much, Chris, and the entire panel. Excellent conversation. I'm looking forward to sharing this recording with a number of my friends. So thank you so much for this, and well prepared. One of the things I'd like to do here is share the balance of our calendar for this year. As you can tell from here, this is our 4th event this year, all virtual so far. We do have our next event in late July. We're crossing our fingers, hoping that could be a hybrid event. We'll continue to live stream these events going forward, but hopefully we'll get a chance to get in person. I know we all want to, but you know, stay tuned for a notice in early July about whether or not that's hybrid or virtual only. But the topic will be care coordination and emerging healthcare delivery models. And that's an exciting conversation, and that the panel is ready to go. So if you want to look for the details on that or to register, you can go to events registration at the TAG online site, specifically the society/health. So you'll see some information there. In September, we have another event. It's probably going to be the 2nd Thursday of September, around new and emerging technologies in healthcare. And so this is the event where we like to try to showcase new technologies that are actually in the marketplace, but you haven't heard of yet, but you're going to want to see them. So there's some really disruptive technologies that we'll showcase there. And then in November, we're going to have a partnered event with one of our sister societies around fintech. So we're looking at the intersection of digital health and fintech. It's not just RCM, but there's other opportunities there to talk about how technologies in both of those ecosystems are combining to improve health delivery of healthcare. And of course, you can always follow our activities in a more live fashion on our LinkedIn page. So if you'd like to search for TAG Digital Health, you'll be able to find that. So I just want to say thank you very much for your participation. As mentioned before, we will have this event recording available on the TAG website in 1, if not 2 weeks, and we'll send out an email notification for that. With that, we are completed for the day. Thank you again, panelists and Jim, for a wonderful conversation. Thank you, and we'll see you next time.
Thanks for having me.
Yeah, thank you.